Bismillahirrahmanirrahim. Today, in regards to respiration, we are going to take up multiple topics, and the first one is that lung volumes and capacities. To proceed with what is a volume and what is a capacity, just think of a balloon before inflation. You haven't inflated that balloon. For example, you have two balloons. One is a larger balloon, and other is a relatively smaller balloon, like this. And you haven't inflated that. There. This is the larger balloon, and you can inflate that with the help of your mouth. But which balloon has greater capacity? Obviously, the B has more amount of air as compared to A. Both of this, say this balloon can accommodate 3 liter of air, and this balloon can accommodate 0.5 liters or 500 ml, right? 3000 ml and 500 ml, or 0.5 liter or 3 liter. So you start blowing it. So we are basically conforming what is the difference between capacity and a volume. So you start blowing it, or you start inflating. You just fill in 500 ml. That is the total capacity it can have. After that, this will burst. So similarly, you just blow it to 500 ml, only 500 ml. Although the capacity of this balloon is 3 liter, but you decided to inflate it till 500 ml. So the amount of air within this at one point is 500 ml, or if you replace the word amount with volume, so the volume of air within this is 500 ml, although the capacity is 3 liter. So if you combine these two volumes, this is one volume, this is one volume, this will become capacity, right? So two or more volumes make up capacity, lung capacity, and this is lung capacity. So this topic is very much important from examination point of view, because usually, it's more than usually, only definitions come in exam in your theory paper. They usually give 4 to 5 definitions, each comprising of 4 or 5 number or 5 marks. If there are 5 definitions, then each comprise of 4 mark. If there are 4 definitions, each comprise of 5 mark. So remember that only writing definitions and the volume or the capacity in ml or liters, you will get full marks. So it's a must attempt question if you find it in your examination. So let's go with the definitions. The first we will see the volume. There are 4 volumes, then we will see the capacities. The first volume, or it is also called the lung volumes or the pulmonary volumes. The first is tidal volume. The tidal volume is defined as a volume of air inspired or expired, just remember that, with each normal breath, and it amounts about 500 ml in normal adult male. So just remember that, normal breath, not forceful. The second definition is inspiratory reserve volume. This could be defined as a maximum volume of gas that can be inspired during forced breathing. So that was with normal breathing, but if you force yourself fully, which you can do right now, in addition to tidal volume, and it is usually equal to about 3000 ml or 3 liter. So very forcefully, if you fill in all your lungs, that is, obviously this is a normal, but there is a reserve volume. As we just took the example of a large balloon, you only filled it in with 500 ml, although it had more capacity, almost 2500 ml more capacity. So you breathe, you blow that away with a very forceful inflation. So ultimately it accommodates around 3 liter of air. Okay, the third one is expiratory reserve volume. That is the maximum volume of gas that can be expired during forced breathing in addition to tidal volume, right? And the fourth volume is residual volume. This you can define the volume of gas remaining in lungs after a maximum expiration. So this you can see, if you maximally expire the air in the lungs, and the remaining volume would be called as residual volume. Then we have pulmonary capacities. A lung capacity is equal to the sum of two or more lung capacities, lung volumes. The first definition, the first is the inspiratory capacity. This equals the tidal volume plus the inspiratory reserve volume. So this is the maximum amount of air, that is about 3500 ml. So that can be inspired after a normal tidal expiration. So that was 500 ml plus 3000 ml. So it equals 3500 ml. Then the second one is a functional residual capacity. This equals the expiratory reserve volume plus the residual volume. This is the amount of air that remains in the lung at the end of normal expiration, and that is around 2300 ml. Then the third, the vital capacity, this is most important, equals the inspiratory reserve volume plus the tidal volume plus the expiratory reserve volume. The maximum amount of gas that can be expired after a maximum inspiration is vital capacity. Then total lung capacity, maximum volume to which the lungs can be expanded with the greatest possible effort, about 5800 ml or 5.8 liters, and it equals to the vital capacity plus the residual capacity. All pulmonary volumes and capacities are about 20 to 25% less in women than in men, and they are greater in large and athletic people than in small and asthmatic people. So that is why athletes have a higher capacities and volumes, so they don't start panting when they start their exercise. So our next topic is respiratory disorders. We will take up certain disorders which are included in your syllabus. For example, the first disorder we are going to take up is the pneumothorax, and it denotes the presence of air in the pleural cavity. You know that the pleural cavity is the outermost covering of the lung. So if it gets ruptured, then the pleural cavity has air in it. So going back to the intrapleural pressure, which we studied in the last, which we discussed in the last lecture, that was slightly negative pressure. So it means that it is subatmospheric pressure, and if the air is present in pleural cavity or intrapleural space, then this pressure will rise up to atmospheric pressure. So it means that lungs would collapse. Why and how? Simply, here, for example, this is the pleural space here. So that was the pressure, intrapleural pressure due to fluid present in the pleural space. That was negative pressure, which actually the direction was this. So these kept the lungs open. But if the air is present within this, then the direction of the pressure would be this. Because now that was a negative pressure, but now the pressure is positive, that is equals to atmospheric pressure, and that is 760 millimeter of mercury here. So it means the direction of the lungs would be to this side, to the right side, and lung would collapse. So pneumothorax denotes the presence of air in the pleural cavity, and this can happen by stab wounds or rupture of some part of the lung. Stab wound, like someone stabs someone with a knife or any sharp object. So as air enters the intrapleural space, the intrapleural pressure rises and equals the atmospheric pressure, which we just discussed. So when the intrapleural pressure becomes equal to intrapulmonary pressure, the lung will no longer expand, rather it will collapse as a result of elastic recoil, and this would be called as atelectasis. So since each lung is encased in separate pleural cavity, so it damages only one lung. So there are certain types of pneumothorax. So open pneumothorax, air can pass freely in and out of the pleural cavity. Closed means air present in the pleura is not free to escape. After some time, air gets absorbed into the blood. And tension pneumothorax, the leak into the pleura has a valve-like arrangement that allows air entrance but no escape. Then we have therapeutic pneumothorax. Sometimes we induce pneumothorax for therapeutic purposes, but now it is rarely used in the modern therapy. So induced therapeutically to cure TB. Lung collapse induced by induction of 400 ml of air in first instance and 800 ml in intervals of 3 weeks. Oxygen of air readily absorbed while nitrogen absorbs slowly. So here you can see a lung has pneumothorax. The second disorder of respiratory system is chronic pulmonary emphysema. And literally, if we define or if we translate this term, it means excess air in the lungs. However, the term is used to describe complex obstructive and destructive process. Obstructive means there is a stenosis, there is a problem, there is a hurdle while destructive means that the pathophysically this disease actually spreads and cause destruction of the lung tissue, and it can be caused by many years of smoking. So the smoker will have a destructive and obstructive problem. So it results from the following pathophysiologic changes in the lungs. And what are those? Number one, pathologic effects are there would be two types of effects. We would be discussing physiologic effects and pathologic effects. Pathologic effects, the first effect is chronic infection. This is caused by inhaling smoke that irritate the bronchi and bronchioles. This seriously deranges the normal protective mechanism of the airway, including partial paralysis of the cilia of the respiratory epithelium and effect caused by nicotine. So if you remember that the epithelium of the lung has cilia, right? And the power stroke of the cilia is always upwards, like they brought about the mucus because we discussed that in anatomy of lung. So they keep or they take the mucus upward towards the pharynx, the power stroke. So mucus is produced by goblet cells. So that the purpose of the mucus is sticky in nature, mucopolysaccharides. The composition of the mucus is the polysaccharides, that is highly sticky. So any bacteria, any smaller particle that enters the airway, that will be entrapped by the mucus, and cilia will actually sweep up that mucus towards pharynx, and that will be swallowed back and simply eradicated. But what if what happens in emphysema, the smoke or the cigarette smoke and the nicotine present in that smoke will cause cessation of the beating of cilia, paralysis. Cilia will lay still, simply like this. They won't sweep, there won't be any power stroke. So simply what will happen? This mucus will be present in here, right? This mucus. But mucus is made up of polysaccharides. That is an ideal environment for bacteria to grow in. So bacteria, these are being entrapped in here, but mucus will stay here because cilia has got paralysis, cilia are not beating up. So mucus will stay here so as a bacteria, and they will start multiplying here. So this will cause chronic infection because mucus is not going anywhere, and the smoker will also not abstain from smoking. So simply this infection will become chronic infection. So this is the first thing that will occur in chronic emphysema. So as a result, mucus cannot be moved. Excess mucus secretion occur, which further exacerbates the condition. 2. Inhibition of the alveolar macrophages occurs, so they become less effective in combating infection. So macrophages that are present in alveoli, that they will also be inhibited, so ultimately infection will prevail. Second, what will happen? The infection, excess mucus and inflammatory edema of the bronchiolar epithelium together cause chronic obstruction of many of smaller airways. Simply, the conducting zone will be blocked by mucus because excessive mucus will cause obstruction. So two things, obstructive and destructive. So the obstruction of the airways makes it especially difficult to expire. Expire means to exhale the air, so thus causing entrapment of air in the alveoli and overstretching them. So simply what will happen, the air will entrap in the alveoli, because there will be difficulty in expiration of that air. So this will actually cause overstretching of alveoli, and this combined with the lung infection, this overstretching causes marked destruction as much as 50 to 80% of the alveolar walls. It is simply that alveoli are elastic in nature. If you keep an elastic structure for a greater period of time in overstretched form, it will actually D-shape. You know that, right? So this will happen with alveoli. So this way it will become obstructive and destructive. Then there are physiologic effects. Number one, the bronchiolar obstruction results in greatly increased work of breathing. Increased work of breathing means simply once for the normal lungs, there is actually no work done by the lungs to exhale the air, but now the person will try to force out the air, because the air is entrapped within the alveoli, and incomplete expiration of the air or exhalation of the air will occur. So person will try to breathe out the carbon dioxide rich air into the environment. So that will actually increase the work of breathing. There will be labored breathing. Then the marked loss of alveolar walls greatly decreases the diffusing capacity of the lung, which reduces the ability of the lungs to gaseous exchange. So obviously alveolar walls will become thick, and actually there would surface area to volume ratio will decrease, so ultimately gaseous exchange will also be affected. So extremely abnormal ventilation perfusion ratio, it means that the quantity of oxygen that is going inside, the amount of carbon dioxide, the exact amount of carbon dioxide will be exchanged with that. That will actually be hampered, because lesser amount of carbon dioxide is coming out because of increased work of breathing. So now lesser amount of oxygen will be entering within the lungs. So loss of alveolar walls result in increases pulmonary vascular resistance, markedly causing pulmonary hypertension. So all with the smoking. So chronic emphysema usually progresses slowly over many years. The person develops both hypoxia, hypercapnia. Hypoxia means lesser oxygen, while hypercapnia means greater carbon dioxide in blood. So because of hypoventilation of many alveoli plus loss of alveolar walls, the net result of all these effects is severe, prolonged, devastating air hunger that can last for years until the hypoxia and hypercapnia cause death. This is a high penalty to pay for smoking. So the next disorder of the lung or the respiratory system is very much common and of particular importance. That is pneumonia. The term pneumonia includes any inflammatory condition of the lung in which some or all of the alveoli are filled with fluid and blood cells. So a common type of pneumonia is bacterial pneumonia, caused most frequently by pneumococci. So this disease begins with infection in the alveoli. The pulmonary membrane becomes inflamed and highly porous, so that fluid and even red and white blood cells leak out of the blood into alveoli. So what actually happens, or here if you see for example, this is the lung alveoli and this is the pulmonary membrane. So this actually gets infected, then it becomes porous. Ultimately what will happen, this is A and this is B. So for example, this is actually the basement membrane. Here are the red blood cell and the blood supply. The air which we inhale comes here, so it just has to cross this membrane, number one, and this basement membrane. Number 2, there is 2 cell thick difference. Then it goes into the interstitium, then it passes to blood, where the oxygen that has diffused inside will combine with RBCs and will be taken up to the heart, and heart will pump into whole of the body. Simply this happens. So this 2 cell thick layer is the only barrier from the environment to the blood. But what actually happens in pneumonia? This cavity or this simply is filled with fluid. Severe the infection, severer or greater would be the fluid, and RBCs here. This will leak in. This will become porous, and the fluid will edema. That will, from extracellular fluid, this fluid will move inside. And actually what happens then? Then the air comes, but it has now a greater barrier to cross. So this will actually cause a difficulty in crossing this membrane. So to exemplify or to make an analogy, just if you have to cross a canal, because this is the canal, you are at this point, you have to go there. What would you need? You need a bridge. So simply you can go over that bridge and cross that canal very easily. But what if there is no bridge and there is a lot of water in the canal? So you cannot just cross, or you have to swim through that water to the other end to make it to the other end. So simply now there wasn't anything. That was excellent exchange, but now there is a lot of water, a lot of you can say there is an edema, there inflammatory process due to infection. Now the air has to cross or swim through to make it to the other end. So this will actually cause a lengthy process. So this disease begins with infection in the alveoli. The pulmonary membrane becomes inflamed and highly porous, so that fluid and even red and white blood cells leak out of the blood into alveoli. The infected alveoli becomes progressively filled with fluid and cells, and infection spreads by extension of bacteria or virus from alveolus to alveolus. Like it starts from 1, 2, 3, so adjacent alveoli are also involved. So in pneumonia, alveolar ventilation reduced, which results in 2 major pulmonary abnormalities. Number 1, reduction in the total available surface area of the respiratory membrane. Obviously, surface area will reduce, so gas exchange will reduce. So this will ultimately decrease ventilation, perfusion ratio. These effects cause hypoxemia and hypercapnia. Hypercapnia is the retention or excessive amount of CO2 in blood. So obviously when ventilation perfusion ratio decreases, it means that the carbon dioxide will be excessive in blood while there would be less. So you can compare, this is the normal, this is a pneumonia and emphysema. In emphysema there is destruction, while if you treat this pneumonia, the membrane remains intact, but it becomes porous, but fluid will fill and red blood cell will fill these alveoli. So the next disorder is asthma. It is characterized by spastic contraction of the smooth muscle in the bronchioles. Just remember that pneumonia is the disease of alveoli, while asthma is the disease of bronchioles. It doesn't involve alveoli. So it partially obstructs the bronchioles and causes extremely difficult breathing, because alveoli are made up of smooth muscles and there are inflammatory responses. Inflammation occurs, allergic inflammation can occur. So allergy can trigger a very intricate process of inflammation, and inflammation can cause the release of certain chemical mediators like histamine, and histamine can cause bronchiolar obstruction, bronchiolar constriction. So that is characterized by spastic contraction. Spastic means it is a continuous contraction. There is no relaxation of the muscle in between. So simply bronchioles are made of smooth muscle, so there is spasm of the smooth muscle of bronchiole. It means that there is consistent and continuous contraction. So ultimately what will happen, the narrowing of the airway will occur, so this will ultimately cause difficulty in breathing. The usual cause of asthma is contractile hypersensitivity, that is allergic, of the bronchioles in response to foreign substance in the air. So the person is allergic to something like dust, like anything. Once it comes in contact with that, like pollen grains, then ultimately hypersensitivity reaction or allergic reaction starts off, and it will cause spastic contraction of the bronchiolar smooth muscles. So in older people, the cause is almost always hypersensitivity to non-allergenic types of irritant in the air. So the sequence of reaction is as follows. The typical allergic person has a tendency to form abnormally large amounts of IgE antibodies, and these antibodies cause allergic reactions when they react with the specific antigen that have caused them to develop in the first place. Simply what happens, this already sensitized IgE, right? Once the allergen enters the airway, this is attached to the IgE, and the IgE will go and start a reaction. So simply, in asthma, these antibodies are mainly attached to the mast cells that are present in the lung interstitium in close association with the bronchioles and small bronchi. So simply IgE attached with that allergen will react. This will be an allergic reaction, will go to mast cells. These mast cells and basophils are abundant in histamine, and other chemical mediators will also be there, released by the inflamed membrane. So degranulation of mast cells and basophil occur, and histamine will be released into the lungs, bronchiolar smooth muscles. So bronchiolar smooth muscles will ultimately, in response to this histamine, will ultimately, for example, these are like dilated, so this will be contracted, and that will be spastic, because this is going to be present for a longer period of time, and as long as it is present, it will remain contracted. So the airway passage, you can see a lot of spaces there, but now there is only one space. So this will actually cause, when the asthmatic person breathes in allergen to which he or she is sensitive, the allergen reacts with the mast cell attached antibodies and causes mast cell to release histamine. Slow reacting substance of anaphylaxis, which is a mixture of leukotrienes, eosinophilic chemotactic factor, bradykinin. So this combined effect of all these factors especially will actually cause localized edema in the walls of small bronchioles, localized edema, that presence of fluid in the bronchioles, spasm of the bronchiolar smooth muscles, and ultimately this will cause resistance to the flow of air, and person may die if it is left untreated. So thank you very much. Next time we will take up gas exchange in lungs, that is the basics, and exchange of carbon dioxide, and oxygen in the lungs. Thank you very much for your attention.